is unable to join us, so she apologizes for that. I'm just going to let 2 more people who are wanting to join. Just admitting 2 more people. Okay, great. So we can start. Okay, so the aim of this talk today is to impart foundation year tips and tricks to make your transition from a medical student to a junior doctor as effortless as possible, and to prepare you for the later years as well as training. In terms of questions, if you have any burning questions during the talk, that's fine. You can always unmute yourself and ask a question, or raise your hand or put a comment, and we can get to those at the end. Or I will have a separate question time at the very end of the talk. If there are other questions that you think of after the talk, please feel free to email us. Our email address is at the end of the talk. And then finally, we ask that you please all fill in feedback for us so that we can also improve on this talk as well as other talks for the future. This QR code does work. It will also be available at the very end. So you can scan the code. It will lead you to a Google link, and then you can fill out the Google form. So just in terms of the contents, we'll be covering an introduction to the foundation program, expectations, tips and tricks of mastering your foundation years, how to create a portfolio, applying for higher training, and finally, finding support. So we'll begin with introduction and expectations. So in terms of what the foundation program is, it's a very well supported program with the aim of bridging the gap between your undergraduate years and specialist training for all junior doctors. There's an emphasis on performance in the workplace, and it's not just like medical school where it was isolated tests and exam situations. Now it's basically an application of all that knowledge you've learned. So you will develop and foster your clinical skills, procedural and communication skills, your attitude, professionalism, and reflective practice. Something about the foundation year program is that at the beginning, you'll find that there's a lot of supervision, and you'll soon learn to be able to practice with decreasing levels of supervision. But it's not expected that at the end you're completely independent. You're still allowed to ask questions, and there'll always be supervision available as a junior doctor, even after the foundation program. You'll also learn how to work as a team and work in a multidisciplinary team. And finally, the foundation program emphasizes lifelong learning in the form of teaching, which you have the opportunity of giving, as well as teaching, which you will be joining every week. So you'll have allocated time every week to join teaching sessions, which each of the departments you're in would have organized. And then finally, supervised learning events, which we will discuss under the Horace E portfolio. So in terms of foundation expectations, you are expected to partake in a variety of clinical experiences. So that depends on which rotations you have chosen. And the main expectations are to undertake a quality improvement project. Actually, you can undertake as many as you would like. Get involved in an audit, get involved in teaching. So there a mandatory number of hours you will need to, of teaching you will need to attend, as well as the opportunity to give teaching in your respective departments, as well as learning. So the main emphasis is on learning, which is under the Horace E portfolio. So in terms of learning, you'll have to document your supervised learning events, as well as reflections on interesting cases you've encountered. And then there's also opportunity for feedback, for others to give you feedback on your practice, and for you to give feedback on the practice of others that you work with. So you'll become very familiar with Horus ePortfolio. There's also a PDF document you can download on how to use the ePortfolio. In terms of exceeding expectations, I think it's a good opportunity to start thinking about, if you don't already know, which specialty you enjoy, and review that specific person's specification for the specialty, and try and tailor your activities to that specialty. And then also, if you're still unsure about specializing, even at the end of F2, that's completely fine as well. It's fine to still take an F3, take an F4, or take a break even, and then give yourself a chance to think about what you would like to specialize in. So moving on to tips and tricks, we'll cover 3 sections. So firstly,
you've been placed on hold. Please wait.
Okay. If that person could please mute themselves. So in terms of tips and tricks, we'll be discussing an approach to an ill patient, how to refer a patient, and finally, opportunities to look for during your foundation training. So we'll start with—
you've been placed on hold. Please wait.
An ill patient. Just trying to see what's going on. Okay, so in terms of an approach to an ill patient, this is basically how to identify an ill patient. You can use the NEWS score, which is the National Early Warning Score. There's an image of it on the side, so it basically looks at respiratory rate, saturation, is the patient on oxygen or not, their systolic blood pressure, pulse, level of consciousness, and then finally temperature, as well as vital signs.
You've been placed on hold. Please wait.
Important to note that in terms of vital signs, sometimes they can be normal. Sometimes the vital signs can be normal because of a patient could be compensating really well. So it's not always the best indication.
You've been placed on hold. Please wait.
Something that is quite useful is respiratory rate. It, in 90% of the time, a rise in your respiratory rate. So hyperventilation is a good early sign of there being a problem. So the patient being clinically unwell. Other things to look at for identifying—
you've been placed on hold. Please wait.
Risk factors. So certain risk factors a patient might have, or comorbidities. For example, the patient has cancer, or have a patient with possible myocardial infarction. You need to look at whether they have other blood-related comorbidities. Sorry, I'm just going to mute this user. Okay. Now we should have some peace and quiet. Okay, sorry about that. I think they weren't aware that they were not muted. Let's just close this quickly. Okay, so as I was saying, comorbidities. So for example, if a patient comes in with chest pain and you're considering a possible myocardial infarct, you need to look at the cardiac related comorbidities and see whether, if their blood pressure is really high, this could also help you identify whether they're really ill or whether it's similar to their baseline blood pressure. So a nice thing would be to look at the previous vital signs, which can be sometimes on the electronic platforms that the NHS uses. So for example, our trust uses something called Cerner, and you're able to look at all the previous vital signs and see if the current admission, these vital signs are in keeping with previous vital signs, or whether there's any changes, and that can be a good indication. And then also a really important source of information is the triage notes. I always read them, as well as the ambulance sheet, which is brought in with every person who's brought in with an ambulance. You can have a look at just their impression of the patient, as well as asking nurses about their concerns. Another way you can identify an ill patient is by talking to the family. They generally know whether this is the patient's baseline or if they have any concerns. And then finally, something that you will learn with more clinical experience is Gestalt. So this refers to basically just a gut feeling that you have, telling you that something's just not right with this patient, and makes you escalate to a senior. So what should you do if a patient is ill? You need to firstly discuss with the senior as soon as possible. Communication is key here. You need to also inform the nursing team and anyone else who is involved in the patient's care. This patient needs to be under regular monitoring, which generally will be in the form of a monitored bed. So what a monitored bed is basically like a resuscitation bay bed where the 3-lead ECG monitoring, SATs monitoring, and blood pressure monitoring are done continuously. This patient will also need an arterial blood gas or venous blood gas. And why you would do this is to look at their pH level to see if they're acidotic or alkalotic and whether they're compensating. And then also the lactate is a really important prognosticator of how they're doing. Another important point is that if investigations are not going to be life-saving in a critically ill patient, you should hold off on these. So for example, you wouldn't want to send someone who has an unstable blood pressure to CT scan because that's not the life-threatening problem at the moment. CT scan can be done when the patient's stabilized. Another important point is to start treatment early. So for example, if a patient is septic and you notice this as they come in, if they're pyrexial, start antibiotics as soon as possible. You should generally start antibiotics within 30 minutes of seeing them. And then finally, early referral. So even if you think a patient is really ill and you're quite sure that they will go to a certain specialty, call that specialty registrar early on, even if all the formal bloods are not out. You can just use the clinical findings and that should be enough along with your gas results. So now we're going to move on to how to refer a patient, which is something I think a lot of junior doctors struggle with. I think it's also a problem with confidence levels, and it's something you'll just become more used to as you go along. So what do I actually say when I refer a patient? I like to use the SBAR tool. It's important to remember that this is a tool, not a rule, so don't feel obliged to use this. It's just something that can make your life a lot easier. So SBAR stands for Situation, Background, Assessment, and Recommendation. In terms of situation, you would talk about, you would generally say things like your name, where you're calling from, and who you're calling about, and what your concerns are, and then just give a brief background on the patient, and then your assessment. So I think the problem is X, Y, and Z, and this is what I've done, or I'm not really sure if this is correct. Do you have any other advice or recommendations you could give? Yeah, so we'll go through some examples of referrals. So other key information you should include is always your name, your grade, and department. Generally, most foundation year doctors will just say, I'm an SHO, because it doesn't actually matter whether you're an F1 or F2. You are a senior house officer, basically. Your reason for calling, and then a brief patient summary and a summary of the management you have already undertaken. And then also always remember to ask for the receiving doctor's name. It's really important to document who you've spoken to and the time at which you've spoken to them, just in case there are delays in that specialty coming down or any problems in the future. Yeah. And then also ask them for advice for any other treatment they would suggest or any other investigations you should have done, and document all of this as well. So an example of referrals would be, I have a 63-year-old male with a news of 5 who may be having an NSTEMI. And then a better example would possibly be, Sorry, I gave you guys the answer. I am an F1 here with a deteriorating patient who is possibly having an NSTEMI. So I was supposed to ask you which of the two you would prefer, but let me just tell you why the second option is better. So in the first one, there's a lot of uncertainty, and sometimes when you talk to a specialty registrar, they're likely going to say, if you start with the first one, if you refer them with the first line, they're probably going to say, can you get one of your seniors to call me back once they're sure of the diagnosis or something like that. But if you go with the second one, just say, it just sounds like you're more sure. Yeah. Another example would be, I have a 47-year-old female with severe epigastric pain with the past medical history of an MI and diabetes versus a 47-year-old female admitted with an MI 3 days ago is having severe epigastric pain. They have a background of diabetes. Which of these two do you all think would get you help quicker? So I'd ask if you can just put some comments in the chat. Anyone? Or if you even want to unmute yourselves and give an answer. The second one, okay, so the person whose name is ... says the second one, and then Kritika says the first one. Okay, any other responses? Okay, so I would prefer the second one. I just feel that telling the referring doctor that, the accepting doctor that the patient had an MI 3 days ago is basically a red flag. Whereas if you just say a past medical history of an MI, it sounds like just more in the past and not something that is a current concern. So I think the second one would actually get you some help faster. Okay, so moving on to what do I do if my referral is rejected? Don't feel bad at all. There's even times where I've had referrals which are rejected. Sometimes they just want you to do a bit more before talking to them. Other times it's just about they would like a registrar to refer, so they wanted a registrar to registrar level, which is not actually a good enough reason. And then also, it's also important to just ask that receiving doctor for the reasoning behind rejecting the referral. And then you can also just reflect on this and improve, basically. If you are feeling disrespected or belittled by that receiving doctor, just remember that this is really unacceptable. You don't come to work every day to be mistreated, and you need to escalate this. Don't be quiet about this. Escalate this to a senior, and then they can continue the referral. No one is perfect, and no one was born referring patients or born a doctor. So everything comes with practice, and you'll all soon learn that it's really easy. And finally, we'll talk about opportunities. So firstly, in terms of research, I think it's really important to speak to your supervisor and other registrars, because generally they will be undertaking some sort of research depending on the department you're in. And then lots of them will be happy for you to get involved. You could also flag interesting cases for potential case reports. Sometimes you can even, if you find an interesting clinical scenario, you could do a brief search on the internet and just see whether this actually is a rare presentation, and then discuss this with your supervisor about the potential for a case report. And then also just take initiative. I know when I just started working, I saw a few posters in my department on different clinical research which was ongoing, and I just took down the details of, so the email addresses, for example, and emailed them and let them know I wanted to get involved in research, and that's how I got involved. So just take the initiative as well. In terms of quality improvement projects, you need to differentiate between a QIP and an audit. So an audit is undertaken to assess whether healthcare is being provided in line with the standards of the trust or national guidelines. And it's also a place where you can identify whether a service is doing well and where improvements can be implemented. So generally an audit will be undertaken before a quality improvement project can be implemented. So a quality improvement project is basically to assess whether, you're basically just improving upon the area you've identified in your audit. You don't always need to have an audit before a quality improvement project, but it's always, doing an audit always helps you to identify service needs which are lacking, if that makes sense. And then when you start in you've all started in your departments, but it's always important to ask your supervisors about ongoing audits and QIPs which are happening. And then something that I found really useful was I attended a quality improvement practitioner course on Learn. So you can just go onto there and search quality improvement practitioner course and you should find it. I was part of the first ever cohort, and I know they are having another practitioner course in November. So that would be really great to join, and you will get a certificate of attendance, which also just helps building your portfolio. Another platform you can use is joining the Life QI online. It's an online platform where you can look at all the different QI projects in your trust as well as other trusts, and then you could find contact details and try join different QI projects from there. In terms of courses and exams, my advice would be to apply for your advanced life support early. The earlier you can do it, the better. And for most specialties, especially I think IMT, ALS is a requirement. In terms of study leave, you, as a foundation F1 doctor, you have 15 days allocated for studying. However, all these days are already pre-allocated to teaching and simulation. So what you could do is that F2s have 30 days allocated. You could borrow a few of the F2 days and request that you take them in F1 if you're looking to write your MRCP or MRCS in your F1 year. And then also look at examination dates early. So if you're planning on doing MRCP, there is a certain time frame within which you need to book. So you need to go on to the Royal College of Physicians website, or if you want to, if you're interested in surgery, go to the Royal College of Surgeons site, and then just look at the dates. In terms of locum shifts, I wouldn't really advise an F1 to do locum shifts, but if you are feeling towards the end of your F1 year more comfortable with managing patients, and you could apply for locums on the trust app called Patchwork. And this is really only if you have time and if you're feeling competent. Yeah. Okay, so now we're moving on to creating a portfolio. So there are three components to a portfolio. Well, three components not to a portfolio, three components to specialty, applying for specialty training. So there's the portfolio, selection criteria, and the person specification. The portfolio is basically a collection of evidence. Selection criteria are what you will use for point scoring to see how you can actually, you will have to do the scoring beforehand to score yourself, and then this will be confirmed, well, compared in your interview to what they think you actually deserve. And then finally, the person specification, which is basically a list of desirable criteria. Okay, so in terms of the portfolio, what to include and how to include it. So you need to get a portfolio, and I think you should all be starting now to gather evidence because there's a lot of evidence you could use from medical school as a baseline for your portfolio. And try and update this as regularly as possible. You don't want to get to a month before the interview and you're still trying to find bits and pieces of evidence. You should ideally keep a hard copy and an electronic copy. So print out various certificates or pictures of you presenting, things like that, and also keep an electronic version in a separate portfolio folder. Because I know a lot about IMT, because that is what I will be doing. Just in terms of IMT, what counts as evidence? This is basically from the IMT recruitment. Also, just a side note, IMT stands for Internal Medicine Training, just if some of you aren't aware of that. So IMT have said it is not possible to be prescriptive about what evidence will be acceptable. The key is that it is sufficient for interviewers reviewing your folder to be confident that you have claimed correctly. So this is basically just saying that on the score chart where you have scored yourself, there needs to just be some form of proof of how you came to your scores for each of the individual sections. Okay. So in terms of core surgical training, what counts as evidence? So they have said that a copy of your presentation, a hard copy, would be sufficient, as well as a copy of the event program, because the event program would likely have your name on it. And then in terms of publications, you should include your PubMed number or a link to your publication if it has been accepted. If your paper is in the process of being reviewed or hasn't been accepted yet, you could also just submit the email to show that you have sent it to a journal and it's awaiting review. So what counts as evidence? So the journal page with your name on it, certificates, posters, slideshows, just make sure your name and the date of the presentation is on there. Various timetables with your names or event programs, as well as feedback forms. So you will see at the end of our talk, we have a feedback form. So that's a similar type of thing you should be getting, as well as emails, website printouts, and pictures of yourself at events. Just remember that there's no point doing all the hard work if you don't have evidence of what you've done. So try focus on getting that evidence in and keeping a copy of it safely. So just remember that if for any reason you don't have the evidence in your folder and you have scored yourself for the section. So for example, let's say you've presented a topic to the Hall of A&E, but in your portfolio, you have no evidence of this and you've scored yourself, I don't know, for example, 3 out of 5 for teaching. You can also, your score can be reduced by the interviewers, or your application can be deemed unappointable, which means that you won't be given an interview and your application will just be scrapped. And then in serious cases, it could lead to a probity investigation. So you really don't want this to happen. So if you do score yourself for something, have a good reason and have the evidence to back this up. So we'll go through some portfolios of, some examples of portfolios from some of my colleagues. So you would have your scoring criteria, and then under that, the score you've given yourself. So for example, in this portfolio, they have scored themselves for postgraduate degrees, 4 out of 4, additional achievements, 4 out of 5. So quality improvement, 11 out of 11. So under each of the specialties which you would want to apply to, you could just search, for example, IMT for medical training or ophthalmology training, NHS, and we'll come up with the exact criteria which you would need to follow. This is for core surgical training. I will go through those criteria in a bit. This is another example of another portfolio. So it's good to have little side notes just so that you're not fumbling about in the interview. So we have a CV, undergraduate training, postgrad medical education, qualifications, clinical governance, audit and quality improvement. Okay. And then another example. So these two images here are not actually evidence. So this is just basically a summary of everything these two doctors have done. And then in the portfolio further on, there would be evidence of each of these things. And then, so I did mention pictures, so you can show yourself at conferences, pictures of yourself next to a poster, or pictures of yourself doing any hobbies that you've mentioned you are involved in. Okay, so moving on to selection criteria. So basically you score yourself, provide the evidence, and you get the points. It's as easy as that. The common selection criteria are generally extra degrees. So during medical school, if you did an intercalated BSc, this counts. If you've done a master's degree, an MD or PhD, what also counts is if you're undertaking a current degree. So it doesn't have to be that you've completed the extra degree. However, if you have completed one, you will receive the maximum number of points. And if you're still in the process of completing a postgrad degree, you will only earn some of the points. So for example, I'm undertaking a part-time master's degree. So that will only earn you some of the points. In terms of prizes and awards, this can be at any point during your medical career. So during medical school, if you were awarded a prize, include this. Distinctions in any exam. So if you received your final medical degree with distinction or honors, just provide proof of this and include it and you will receive the points. Then presentations, provide evidence of any posters which you have presented or posters or orals. And then you get the most points if it's an international presentation. And then you get a few, you get less points for a national presentation and then fewer for a regional presentation. And then in terms of publications, generally they want you to be the first author, and it's generally the best if the publication is on PubMed. Those are the two requirements. So you can be the first author and on PubMed. Sometimes you can be the second author if you also the first author on a paper. In terms of teaching, so you get the most points for developing a teaching program, which runs for more than 3 months. But just performing or undertaking teaching in your local department also gets you points. Yeah. In terms of quality improvement projects, you need to have completed 2 PDSA cycles. So PDSA just stands for Plan, Do, Study, Act. It's just a cycle of a quality improvement project. So you need to have run through a quality improvement project once, seen what worked, what didn't work, and then run through it again. And then you will get maximum number of points. So I think for medical training, the points out of 10. And if you do 2 cycles and present this quality improvement project, you can get 10 out of 10 points. In terms of leadership, you can provide evidence of any leadership skills you have shown, basically. So if you were the class captain in medical school, or if you were the head of like the surgical society in medical school, or if you're part of any extracurricular activities where you're a leader, those are good examples. Also, if you're another example I was thinking of is, well, it wouldn't really be applicable to you now, but if you're undertaking research and if you're basically the lead clinician, then that shows you leadership skills. It's anything where you show that you're basically leading, and yeah. Just something I left out under teaching is that it's also a good idea to attend a teaching course. So a training course. I'm currently doing one online, but they're also face-to-face ones, which you can attend, and that will also get you more points. Yeah. In terms of person specifications, you always need to read the fine print. So you'll need to search the person specification depending on the specialty you want to pursue. There's a difference also, you need to notice the difference between person specification and selection criteria. So person specifications are basically just desired criteria, well, desirable things that you should have, and then the selection criteria are what gets you points. So person specification, they will include essential criteria, qualifications, clinical skills, academic skills, personal skills, probity, and commitment to specialty. So essential criteria, for example, might be that you have I think I have an example of this. Let's just go through this. So an essential criteria is here under qualifications, the applicant must have a medical degree. This is for internal medicine training. And then in terms of eligibility, so the applicant needs to have 12 months of medical experience, either in the form of a UK foundation program or having been awarded the equivalent of this, or 12 months of medical experience after full GMC registration. This won't really be applicable to any of you because you're all doing the foundation program. And then be eligible to work in the UK. And then also, you see, have the Advanced Life Support Certificate from the Resuscitation Council of the UK. And then the next aspect is the applicant needs to have fitness to practice. This is in the form of references and then in terms of language, but I doubt any of you will have a problem with this. You need to all speak English and provide evidence of this if you are an international medical graduate and your home country, if in your home country the main language is not English. And then in terms of health, they will just ask you to fill a pre-screening health form, which is pretty simple. You just have to declare any chronic medical conditions that you have, which could affect your clinical practice. Yeah. So in terms of applying for higher training, you really need to start looking at the person's specifications and the selection criteria early on so that you know what to expect. So there are many training programs you can consider. I've talked a lot about the internal medicine program. There's also general practice, core surgical training, acute care common STEM training, pediatrics, obs and gynae, psychiatry and ophthalmology. And also the key thing to remember is that you can apply to as many as you like. I know on oral, they generally say that you should apply to one, but I know many of my colleagues have applied to more than one, and that's completely fine. You just need to, at the end of it all, if you get accepted to all of them, you need to just bear in mind that you will have to choose because it is a bit unfair to the other candidates who would also like to be considered for the other specialties. So this is basically the platform Oriel where you apply for training. So you'll need to create an account, log in, and then fill in your application form here. And then just in terms of the timeline, so applications generally open in November 2020. Interviews are held in between January and March of every year generally. In March, you generally get an offer, and then by the end of March, you need to either upgrade your hospital. So if you've been given a certain hospital and you would like a different one, you can also apply for that. And then it all ends on the 25th of March generally. Well, this is what it will end on the 25th of March in 2021. In terms of training programs, so what has changed? Recently in 2019, core medical training has changed to internal medicine training. which basically has been changed to allow junior doctors more experience before becoming a medical registrar, and also lets you embark on a dual versus a single certificate of completion of training. So this means that if you would like to do gastroenterology, you could say that you're internal medicine specialist and a gastro specialist, for example. For some specialties, you might need to sit something called the MRSA, Multi-Specialty Recruitment Assessment. As far as I'm aware, you need this exam for radiology, ophthalmology, and I can't think of another one off the top of my head. And for GP training, yeah. If you score in the top 10%, in most for GP training, there's no need for a portfolio interview. So you will go into GP training straight away. And if you score in the top 10% for ophthalmology and radiology, you generally just get more points towards your application. Okay, so we basically talked about this. In August, you'll be able to view the programs. In October, you can apply, and then from then, shortlisting occurs and interviews. And then finally, January and February, you will receive offers, with interviews generally being at the end of February to March. Okay, so a very important topic is support. I never want any of you to feel overwhelmed or alone. There are lots of places where you can get support from. So finding support, some of the avenues are to talk to your supervisor. So you should all receive a clinical and educational supervisor. A clinical supervisor is basically deals with the clinical aspects, and then an educational supervisor just makes sure that you're meeting all your educational needs, so you're attending all your mandatory education, and you're also getting the most out of the program in terms of education. If you've got a serious problem, speak to your supervisor. They're generally very understanding. You can also speak to your colleagues. There's also the local faculty group, which most departments have, where junior doctors can give feedback. It's generally anonymized, so you can give feedback about anything and everything. There's also the junior doctor forum, where you can give feedback. If it's really serious, you can involve the training program directors. There's also something called the Guardian of Safe Working, which you can Google and send them an email, as well as the Champions of Flexible Working, something you can also Google and drop them an email. Other organizations which are really good are the BMA. This is a poster here on the side from the BMA. Just with the COVID pandemic, they've created this poster. So to check in with each other, yeah, you can basically just go through the poster in your spare time. Yeah, just be kind to each other and support each other, and make friends with your other F1 colleagues, make friends with your seniors. Yeah, there's also an organization called Doc Health, which you can do a Google search on, and then also ask for their help. I think one of the last two you actually have to pay a subscription to. So I think you can, if you've exhausted all the first avenues, maybe you can think of the last two. And then finally, Doctor Support Network. And then there's also really good trust counseling services, which are completely anonymous. So it's something you can consider. So these are some of the organizations. So the BMA has a helpline number here, which offers confidential and 24/7 counseling. I think a nice thing about it is when I was reading up on it on their site, they mentioned that it's doctor-to-doctor counseling. So that's quite nice. So it might be someone who actually understands what you're going through. And then the Doctor Support Network. And oh yes, so Doc Health is actually the one that I think charges you a fee for their services. Okay, so a brief summary of what we've spoken about. basically your foundation years are your time to explore, make the most of it because it really goes by so quickly. And don't try to be hard on yourself. Remember that you're still in training. Also, don't try to take on too much. I know that the thought of portfolios are daunting and the thought of specialty training, and I know you all want to be the best, but also just make sure that you have enough time to rest and relax. But also just be proactive in finding opportunities. Start looking at selection criteria if you're looking to specialize. And then if you're having any difficulties, please seek support. You're all going to be amazing and you definitely deserve to be helped. Even if you would like help from me or Natalie, you could email us. Our email address is on the next slide. You can also email us about other topics you would like to be covered in the future. And then, yeah, so that's the end of our talk. Thank you very much for all of you for spending an hour of your time on a Friday night. And if you could all please fill in this feedback form, would be greatly appreciated. Thank you. Do you have any questions? Any tips for specialty interviews? I think basically you need to, depending on what specialty you're looking to apply for, there's different layout for each of the interviews. So for example, for medical training, there is a there's a portfolio station, a clinical scenario station, and then one on ethics and audits and QUIPs. So another question, which is, so it really just depends on the specialty.